Thank you so much for being here tonight. We have cause for celebration tonight. I don't know if you're aware of that. We're celebrating you. Oh, this slipped down. So we're celebrating you, and we're celebrating the core business mixers, because today, you might not know, is the second anniversary of the core business mixers. So I think it's appropriate to have an applause for you guys, and also for Ann Tyson, her husband Jose, for 2 years have been supporting these events. These events, as you may know, CORE stands for Challenges and Opportunities for Something. Originally, it was for Ratonian entrepreneurs, and now it's for regional enterprises. It has grown so much. So let's give a hand to you guys and to Ann and her husband Jose for supporting these events. So Ann is doing a beautiful job with her husband of memorializing what we're talking about here. So I'll go through just an introduction of what we're doing here tonight. How many of you have already signed in on our sign-up sheet? It's over there at that table. If you haven't had a chance to sign in yet, just wave your hand and it'll get passed over to you. We have some business cards over here. You're welcome to take them. And if you are a business owner or a nonprofit owner and a nonprofit leader, and you would like to weigh in on what we need to do to be of service to you, there is a survey that Ann designed that we are conducting to get a better understanding of how we can be of service to you, not only at these events, but also in some new opportunities we're offering for you. So if you haven't, how many of you need to take a picture of this, or need to make the link there? Are you all good? All right, so we'll move on. So we are starting something new this year. We had tested it out over the prior years, and what we want to do is regularly walk around town and meet with you guys and have a better understanding of what you need. Some of the things we already know are folks need websites, folks need some presence, digital presence on Yelp or Google. We need signage to pull people off the freeways to make them aware of you. And we're going to learn more and more about how we can be of service to you. So the more you participate in these surveys or talk to us when we're doing our walkabouts, our walks and talks, we'll be able to serve you more and more over time. So on the first and third Tuesday of every month, that's the opposite Tuesday of the commission meetings, we're going to walk around town, and then we're going to have office hours at night. The office hours initially may be at the Tourist Information Center. We'll see how many people show up. And our job is to make you guys successful in whatever way you want to be successful. So you'll see that happening, and then we'll make adjustments based on how well it works or what you guys tell us that you need. We're very grateful for our hosts here at the restaurant, and also for our presenter, Brian Cotter, who I'll be introducing momentarily. And if you are interested in having one of these events at your location or at a different location, let us know and we'll try to plan that. I am not Ann Tice. I am Cynthia Laura Molina. I'm the Director of Community and Economic Development for the City of Raton. I've been in town for about a year and a quarter, and it's just been a real joy to get to know everyone and the community. Ann is busy behind the counter, so that's why I'm presenting her slides here. So in rural America, we have a challenge. And our challenge is really threefold. We need to drive up well-being, the well-being of our community, our productive capacity, which means basically how much are we able to contribute to our community, and also our socioeconomic status, like can people afford to buy groceries and have health care and have housing and so on. And so those three things are kind of haunting to us as a community, just trying to make sure we're making the most of that as individuals, as organizations, and as a community overall. So we're very fortunate today to have someone with an unbelievable background in healthcare, who also has been a service member in the U.S. military and who has a clinical background in addition to having an MBA and in addition to doing turnarounds for a living. And he's super smart, and he's done a lot of different kinds of business turnarounds, some of them really focused on the clinical care that's being provided, whether it's acute care or whether it is post-acute care. He also understands insurance and insurance billing and medical records and how to make sure there's enough revenue. He knows how to design operations inside different facilities. And so we're going to hear more and more from him tonight. But before we get started, just to help him understand who's in the audience, how many of you folks have used MCMC, Miners Colfax Medical Center? How many have been in the emergency room? How many, here's a question, how many have been in the emergency room, but what you really needed was primary care? Okay, and then how many are using a broad range of medical services locally? How many of you are using a broad range, lots of different types of medical services locally? Like, do you use other local healthcare services? And how many of you have ever left Raton to get medical services? All right. And how many of you have used telehealth services? All right, and I'm going to ask a weird question. How many of you have used digital health services, like an app, a healthcare app on your phone? How many of you wish we had more and better healthcare here in town? All right, so it seems like we might have gotten the right speaker for today. So that's pretty cool. So if you're interested in learning more about any of the topics we cover tonight, or interested in learning more about the core business mixers, again, challenges and opportunities now for regional enterprises, contact Anne. And if you can't reach her, then contact me, and we'll be as of service to you as we can. So my contact information is up here now. And we also have some partners in town. So we have some economic development partners through Grow Raton, through the Center for Community Innovation, and through Raton Main Street, as well as the Raton CDC, I just zoned on the name, but I'll remember in a minute. Paul, do you want to jump in on that and remind me what CDC stands for?
Raton Community Development Collaborative.
There you go, the Raton Community Development Collaborative. So get in touch with us if we can be of service to you, and it'll be just a pleasure to help you as much as we can. So now back to Brian. You know what I noticed about Brian is when he came to town, he showed up at City Hall. And at the City Commission, he immediately introduced himself to the community. And the events that I've seen in the city, he has been at those events. And he's brand new here in town, and he's already making his presence known. And I can tell that he genuinely cares about the community and being a part of the community. So like I said, he's a former military veteran. He has over 16 years of work as an RN in the emergency room and ICU and other places before he moved into administration of healthcare and ultimately very high-level leadership and turnarounds in healthcare. And I think that's important because you can imagine if we get a CEO of our hospital who's just kind of a number cruncher, or we get someone who's just about the profitability or just about volume, we're not going to get the kind of care that all of us need. So it is an honor and a pleasure to be able to introduce to you a man who has all sides of the equations, all three legs of the stool, in supporting the clinical and financial and administrative well-being of MCMC and of the community. Brian, please.
Good evening, everyone. My name is Brian Cotter. I'm the CEO of Miners Colfax Medical Center. Thank you so much. It's really an honor and a pleasure to be here to talk with you all. And I think I've met quite a few of you already at different places in town. And I'm still getting to remember names and everything. I think I've got everyone down at the hospital. I think I've got everyone's names set there. Which is a lot of fun. Some of you I met kind of by I don't want to say on accident, but in serendipitous times. One of the recent snowfalls, I was driving down 6th Street and I saw this adorable little puppy dog, just kind of bouncing around in the snow, and I thought, oh my gosh, there's a little cute little puppy dog. Is it a Chihuahua? Yeah, a little Chihuahua just bouncing, like 4 or 5 inches of snow, and he's about 3 to 4 inches, and he's or she, and I said, oh my gosh, I got to pick up this little puppy dog. So she came up to me, and I'm holding it in my truck, and she's shivering, getting warm, and I'm driving down, and I see a woman in her car getting ready to go to work, and I'm thinking, okay, the dog came from somewhere, and so I stopped and got out, and I met Bernadine. And I said, hey, here's a dog. Well, I think it's Mr. Tinkles or something like that, Mr. Tinker. And I thought, well, okay, all right, great. I just wanted to make sure. And if I had not seen Bernadine that morning and figured out who the dog was, I was going to show up at the hospital with a new dog and get on Facebook and try to figure out, whose dog this was. But it was killing me that I saw this cute little puppy dog running in the snow, and I thought, no, this can't happen. So it's been a lot of fun. Cynthia mentioned that I went to the City Commission meeting back in December, and they were talking about the movies and the film, and so we got to talking about that. And I met Terry Sagata. I met a bunch of folks at different. Met Neil and a bunch of folks. I hit up the coffee shops when they're open. And I've been hiking on the trails, and I love to swim at the aquatic center. You've got the best pool, the aquatic center here. So, yeah, no, absolutely. I got to know some of the lifeguards. So Cale Walton, he's a nice young man, and his sister Baylor, she's going to nursing school, so we're going to try to recruit her to be a nurse when she graduates later this year. I got to meet JR, and a couple of the folks that swim. So we got a couple of regulars in there that swim every night. So I'm usually in there 3-4 nights a week if I can. So getting around. I went to the museum, the Raton Museum, when they had their open house. Oh my gosh, that was so cool. And I was really impressed by that picture of Dawson, the town of Dawson, when it looks down over, I think it was like a store, some sort of store. And somebody was telling me about it, and I was just, wow, the rich history of the mining and how the towns come and kind of ebb and flow, and I was just really, really impressed with this. And saw the Schuler Theater. I went to a couple of performances of the play there over Christmas, and that was Schuler Theater is amazing. It's beautiful. You have so many gems here in Raton. It's pretty amazing. So yeah, I love to hike. I've done the Lake to Lake Trail. I did the first day hike around Maloya. I've done the Climax Canyon, the West Loop. And so I love the outdoors. And that's one of the reasons that attracted me to this location was the outdoors. Like I said, I've been working in LA, Orange County, Phoenix, Illinois, in big hospitals, big urban areas. Last year, I was working in East Hollywood at a big hospital I was a revenue cycle financial consultant for a 400-bed hospital there. And I'm driving, flying into Ontario, or I'm flying into Burbank every week, staying in a hotel in Glendale, driving through, Hollywood and stuff, get to the hospital. And what a nightmare, what a mess, right? What a mess. Come here and, if I have to wait 30 seconds for a car, that's traffic. And it's great. I love it. The beautiful views. It is just, I almost think that, Raton was made for me because it checks all the boxes for me. And everyone I've met here has been really, really wonderful and welcoming, and I appreciate that so much. And the hospital, I love the hospital. It's a beautiful building. We've got some really talented people there and people that want to do good things. So I think it seems to be a really good fit. So with that, I will move on. I can talk, okay? I can talk. So if you want to go 2 hours, hey, I can stretch it out for 2 hours. Not a problem. But I don't want to do that. So when I'm going through these slides, please stop me. If there's a question or a comment, please stop me. I don't want to wait to the end. I mean, we can wait to the end, but I was thinking, why don't we just keep this interactive? So just raise your hand or make a comment and I'll stop and we can talk about it. I'm very interactive, okay? So our mission, mine is Colfax Medical Center, and you probably know more about the history of the hospital than I do. I know it was 1906, I think it was 1906, with the land grant, the land trust fund. And so there's a lot of support, and it's owned by the state of New Mexico. The healthcare agency, of the state of New Mexico, and our mission is to be the leading provider of quality acute care, long-term care, and related services to the beneficiaries of the Miners Trust Fund of New Mexico and the people of northeastern New Mexico and surrounding regions. And our vision, Miners Colfax Medical Center, partnering with other healthcare providers who share our values, will be a leader in providing healthcare services. The medical center shall continue to service the minor beneficiaries and the public. So when I mentioned, getting to know the town and looking at the rich history here, I love history. I love history. If I wasn't in healthcare, I'd either be some sort of history professor. And I think when I was growing up, I wanted to be Indiana Jones. That was my dream. I wanted to be Indiana Jones because I love adventure. I love history and just discovering things. So when I see that history and then I connect the dots and I go to our long-term care center and I see the history on the walls and I see the history walking the halls, with the miners that are there, I think of, the hard times that they went through, back, 100 years ago and up until not too long ago, the backbreaking work that they did and the risk, the health risks and the life risk that they took to build not only the city, but the region and the state and the country. So doing the coal mining, the sacrifices these men and women did for their families every day to put bread on the table, okay? And they did backbreaking work that, today we would just think, oh, I would never do something like that. So these men and women that did that and the miners that built this town and built the state and the country with everything that they did with the raw materials, we owe that to them and their legacy. And so when I'm getting to know the mission and the purpose, I'd like to connect mission and purpose with what we do, connecting mission and purpose. So when I read these missions and our visions, I don't want it to be just a statement on a slide or on a wall in the hospital. So I want us to live our mission and live our vision. So something that Cynthia said, I've been in healthcare for 40 years. I started out in the military. I was in the Air Force. Your name Paul? Paul? Yeah, Paul, I saw your hat. You're an Air Force veteran, so am I. I spent some time in the military, had a lot of fun, but I love that idea of service and giving back and having a dedication to certain core values. I believe in that. That's what I enjoy. So I was in Izmir, Turkey. I was in Turkey for a while. Then I was stationed in Northern California. Then did some time in Desert Storm, did some Aerovac stuff. But I was an ER nurse up in Northern California in the Bay Area, so I worked in some trauma centers. I taught a lot of paramedics. I worked in level 1 trauma centers, worked in ICU. I was a house supervisor in the 90s. And so I got to know hospital work inside and out 24/7. At one point, I think I had 5 jobs. I was working 2 or 3 hospitals at the time. I was in the reserves. I was on call for EMS transports and all this stuff. But I just love it. It was a lot of fun. And I got on the business side in the 2000s in what they call LTACs, long-term acute care, and then acute rehab hospitals and skilled nursing facilities. So I see I see the big picture of healthcare, the integrated system. Then I had a very interesting experience back in 2011 to 2013 in Anaheim, California. I had a hospital. It was part of a system, and it was. So I'm a sucker for lost causes. Okay, I am a sucker for animals, kids, lost causes. So a friend of mine calls me up. He goes, "Hey, I got this great little hospital in Anaheim." I said, "Okay." And he goes, "It's a 100-bed hospital." I said, "All right." And there's there's a second unit up in Buena Park. I said, "Okay." He goes, "It's losing about $1.5 million a month, almost $2 million a month." Okay. I said, all right, I can deal with that. It's been decertified by Medicare. Okay. All right. It's up for sale. Okay. Okay. It's up for sale. And we have there's a pending DOJ lawsuit for about $60 million. Wow. Okay. All right. All right. No problem. I'm good. I said, what's good about it? He goes, no, true story. I go, what's good about it? Because he's naming off these things. Hey, it's losing a couple million a month. It's been decertified. You have no ambulance services. You have no outpatient surgery services. It's up for sale. And there's a DOJ pending lawsuit against the system. Okay. He goes, I go, what's good? He goes, well, it's 3 miles from Disneyland. It was right on Ball Road, Ball and Western, between Western and Knott, right down the street from Disneyland. I said, sign me up. And he was a good friend of mine, so I said, Mike, anything for you, I'll come and do this. And sure enough, so within about 10, 12 months, and my focus was operations, business development, physician contracts, and just building things. And tell me something that can't be done, and I'll say, okay, we'll get it done. And so in about 12 months, we got the paramedic receiving back, we got outpatient services going again, and we started to make money on EBITDA, on paper. So we started to make some paper money. In about 12 months, I think we showed a $100,000 positive on this. Re-recruited a bunch of physicians, so we got some things rolling. And then we were owned by a German gentleman, and we settled with the Department of Justice, settled with the DOJ. And I think we settled for like $19 million or something. So, and this happened 10 years before I got there. So my name is on the guilty plea. But we fixed it. And he told us over in Germany that he was going to take care of the settlement. He was going to make the installments. Well, he never did. So he never did. He left it to us. He just never returned our phone calls. So we had to owe the $19 million. Oh, sorry. So we had a cash crunch, and I was not very well educated, as most hospital CEOs are not, in the details of revenue cycle, how cash works, how you get paid. I just didn't know it, and that was normal. And not only my paycheck, but the employees of my hospital, our paychecks were bouncing. We could not cash a paycheck for months and weeks and months. So I was getting a paper check every week. I would take it to US Bank, and they just push it right back to me and said, sorry, we're not gonna take it. Or if they did take it, they would reverse it the next day. I would have money for about 12 hours, then they would reverse the money. So imagine living in Orange County and being a hospital CEO, and you pick up your son from baseball practice one day and go to Carl's Jr., and your card is returned to you saying, sorry, sir, you don't have any money. So fortunately, I had $5 in my pocket, and I bought my son a cheeseburger. So I'm an Orange County hospital CEO, and I was supposed to be rich, and I was broke because we had no revenue cycle. We couldn't pay our bills. Yet on EBITDA, we had a ton of money. And we, it was kind of a long story, but we ended up shutting the whole hospital down, the whole system down. So I had to shut down, me and another gentleman shut down 7 hospitals one day between LA and Orange County. And I'll never forget, April 9th, 2013, 6:15 p.m., I'm in Buena Park, shutting down. The last patient was leaving our subacute unit. And I turned off the lights and I said, okay, God, never again. This is not gonna happen ever again, because I saw the pain in hundreds of people, of not only patients, physicians, but my staff and myself not having a paycheck that would clear. And it was horrible, but it was a great experience. We proved it could be done, but the finance side, and I didn't understand write-offs, adjustments, collections, denials. I didn't know any of that stuff. So I said, okay, never again, God. Said a little prayer. And since then, I made it a mission and a point to ensure hospitals that are in financial issues, we get the money that you work for, that you do. And so since then, I've done a number of hospital turnarounds, large and small. So it's been a lot of fun. So again, it's personal for me, mission, vision, and I'll never forget those times, because it was one of the hardest times in my professional life to go through, because you have 150, 200 people that you're responsible for personally. Your housekeepers, your maintenance, your nurses, your folks in the cafeteria. They're your people. You're responsible for them. So that's kind of how I feel. Anyways. Here's our leadership team at the hospital. Lonnie Medina is our chief financial officer. I think Lonnie's been there about 7-8 years. Rhonda Mignot, chief nursing officer. I think she was the clinic director, and she and Dr. Lopez put the outpatient clinic together. She's been there for a long time. I don't want to make her sound old. She's not, but she's been there for a number of years. Crystal Armstrong, she is the chief integrated clinical officer. Crystal came into this position, I think about 5-6 months ago. She's a great fit. And you ask yourself, what is a chief integrated clinical officer? What is that? Well, she integrates different departments: lab, x-ray, pharmacy, utilization review. So she is kind of in between nursing and the business side of it, nursing and finance. So she helps coordinate a lot of the outpatient services that you see. Usually this role is the chief operating officer in hospitals. So they are they would be over lab and x-ray, cafeteria, security, those types of departments that are kind of not clinical, but not accounting and business office either. They're kind of the operating businesses. So that's what Crystal does. She's doing a great job in that. Ray Hager is our director of quality. So she does quality and infection control. Barbara Duran, human resources director. Barbara's been there for a long time as well. Great person to know the history and what has happened in the hospital and knows a lot of the details. And then Stephen Kelly is our long-term care administrator at the Long-Term Care Center up on 6th Street in Cimarron. Rhonda, Crystal, Ray, and myself are all nurses, are all RNs. So it doesn't say that up there, but so Rhonda, chief nursing, obviously she's an RN. Crystal is an RN, and Ray is an RN, and myself. So we have a lot of clinical perspectives in the leadership at the hospital. So, and it's not common to have a CEO who's an RN. It's not that common, but I think it should be. No, really, because I started when I was 18, so I was a CNA, I was an LVN, I was an RN, I was a house soup, just made my way. So I've seen everything in a hospital, and I don't think there's anything in a hospital that I haven't done. Mop floors, made food, been to the pharmacy, you name it. Worked night shift for 10 years, so I understand and appreciate the hard work that everybody does every day. I mean, I honestly do. I go down there and say, hey, I appreciate you guys working nights on this weekend or whatever. I'll stop in, and I love rounding on the units and talking to folks because, hey, I've been there. Administration plans initiatives is going to be instrumental in advancing our mission. Oh, one person, you know what? I'm going to go back here. I need to fix this slide. I left off probably the most important person in here, Leslie Fresquez. I don't know if you know Leslie. She's my assistant. Without her, this thing wouldn't have happened. And without Leslie, my day wouldn't happen and the hospital wouldn't work. And she's kind of new to that role as well, and she's fantastic. And without Leslie, it would be a very difficult job for me. She's great. Leslie's great. So I need to put her on here because she's the one that keeps everything together 24/7. So that's our mission. The hospital went through 2026 strategic planning. Now, our fiscal year is July 1 to June 30. So we're on a fiscal calendar, not a January. So we're on a July 1 to June 30 planning for budget reasons. So I came in December, the week of Thanksgiving, and much of the strategic plan for 2026 was already done. That's good and bad. Good that, okay, I don't have to worry about it that much, but it's bad. I didn't have input or influence over it and to see what it was and put my flavor on it. So I added to it this year some of the things that I wanted to see us accomplish in this, and I'm looking at 2026 as a calendar year, and it's going to overlap with our budget years as well. But build upon our clinical programs, continue to recruit providers, increase access to care, continue to improve our financial health, connect to the communities, all the communities, whether it's Raton, Cimarron, Springer, thank you, Des Moines. Des Moines. Hey, I went to the cowbell tournament, and that was a lot of fun. And so I'm sitting there watching Des Moines and I think Springer, or I think there's another little town that was there. And I'm googling these towns, right? And Des Moines, I think a population, I don't know, 150, 120 or something like that. Yeah. And I'm thinking, how are they getting these super talented? I mean, these kids are good on the basketball court. How are they getting 10 kids to come out here, that are that good out of a town of 120, 130 people? So I was like, good for them. So again, I like going to that because it showed me what the community is and how we can meet those needs. So I was impressed. So connect to the communities. Rural health transformation, that's been in the news quite a bit. We're going to talk about that for a little bit. Long-term care, and that's our mission to the miners. And that is probably the bedrock and the foundation of this hospital. It is the bedrock foundation of the hospital. There are a couple of non-negotiable services that we provide that are non-negotiable. They're not going anywhere, and this is one of them. That is one of them. And the Black Lung Outreach, that's another one. This is an amazing. Dr. Sood and Kim, I'm blanking on her name right now, Kim and Stephen in RT and the folks that do the Black Lung Outreach are just amazing. And again, I'm getting educated on what the miners and everyone has done. And I was talking with Dr. Sood the last time he was here, and we got to talking about the rare earth. And I said, hey, you know what, Dr. Sood, what do you think about the rare earth, mining? And because, normally it was originally for coal. And, and I'm thinking in my head, wait a minute, we're in this competition with other countries around the world, and we're going to be expanding, uranium mining and other rare earth mining and all this. And I'm thinking of the mining process. Well, it's going to get finer and finer and finer in the particulates, right, that we're mining out because they're so small. And I'm thinking, okay. Then I was thinking clinically. I was like, well, if you get finer and finer dust, HEPA masks and filters and all this stuff, they're not perfect. So this stuff is going to get deeper and deeper into your airways and your lungs. We're going to have some more issues that we didn't know about probably in 10, 20 years. It's just, we don't know what we don't know yet, right? So we started having this discussion, and he goes, yeah, Brian, there were, somebody was just talking about that on CNN the other day or something. I said, okay, well, at least I'm on the right track. And so the black lung so I don't see any end time frame to this. As we go into the rare earths and the minerals, it's just going to get worse and worse and worse with folks working in these mines. And so I think this mission is going to be around for a long time to come. And that's something we have to do. And when I was learning about this, that I think we're the only one in the country that has this outreach and this program. And I'm thinking, hey, I've been in healthcare for a long time. How come I didn't know about this? So I want to be able to broadcast this message out there and let the world of healthcare know this is what Raton does. This is what Miners Colfax does. So that's something that I'm very intrigued about. So we had last week, I had 3 town hall meetings at the hospital. So we have a good senior leadership team, and I've talked with them quite a bit. Kind of came out the gate talking with the senior leadership team. We moved it. Then we had a very similar conversation with the management team in the hospital. Everyone's asking me, Brian, what are your expectations? And they wanted to get to know me, and I want to get to know them. And so we kind of, set the stage and level set a little bit. So we did it with the senior team. We did it with the broader management team, what my expectations are. And my expectations are actually very, very simple. Very simple. Number 1, we take care of the patient. Number 1, take care of the patient. Number 2, we take care of each other. Take care of each other. And I said, number 3, if you do number 1 and 2, you're going to take care of the hospital. It's very simple. Take care of the patient, take care of each other, take care of the hospital. So it falls under that umbrella. So I'm a very actually simple person. If you do those things and your intentions are good, those are my expectations. If you fall outside of that, well, we're going to have a different conversation. But I will get you there. And so we did that. Then the next step, from senior leadership to the managers, I wanted to have town hall meetings. So we broaden it to everyone else in the hospital, kind of hear the same message and have that conversation. So we had 3 town hall meetings last week. I think they were very well attended. good questions and dialogue, and we went through a lot of what I'm going to show you here to kind of give them an idea. We're going to have town hall meetings. We just had them in January. We'll have another set of town hall meetings in May, to give a mid-year update. Then we'll have some more town hall meetings in October and November to give them a year-end wrap up and how we did in fiscal year. Oh, sorry. I was kind of getting out of the light.
Well, you're getting blocked by those lights.
Yeah, I know. Yeah. So we'll have some wrap up towards the end of the year. So I want to have periodic town hall meetings to keep that communication and that accountability. If we're going to say something, then we better do it, because then I'll have the staff asking me, hey, Brian, why didn't you keep your word? Why didn't you do this? So I want to keep that accountability and that transparency with folks. So I'm very transparent with people too. I think Dr. Cotter is learning and very transparent with the board. And I promise to shrink that down a little bit. So yeah, I sometimes I over communicate, and it's a lot of fun. But I don't ever want to hear, Brian, you didn't tell us about that. So I want to get away from. I don't want that to happen. Okay, so where we are now, senior leadership sat down in 2025, and they looked at MCMC's current strengths, challenges, and market position. Where we want to be, we established clear, measurable goals for 2026 that align with our mission and vision. And how do we get there? Strategies and action plans. We have strategies and action plans to be set forth to achieve our 26 goals. And the senior leaders actually, every month at the board meetings, they take turns and present to the board the progress and the progression of their strategic initiatives to the board, so they have accountability as well. And we have senior leadership team meetings every week, and so we cover these. And I want to make sure again that we're doing what we say we're going to do. I have another thing of three things. I know Cynthia likes threes, and I like threes as well. Plan, predict, and prepare. The 3 Ps: plan, predict, and prepare. We've all been in business and life, for a long time, and we can figure out, hey, if something happened before, it might happen again. And so again, plan, predict, and prepare. I mentioned to the board last time at our last meeting, I'm looking at, kind of like driving a car, I'm looking at what's immediately in front of us in the headlights, but I'm also looking a mile down the road. And I'm looking at 2020. I'm looking at the first quarter of 26. I'm looking at the month. I'm looking at the quarter. I'm looking at mid-year. And I'm also preparing for 2027 in the back of my head. I have building blocks in segments of programs that we can roll out and develop over the next. I already have an 24 month plan in my head of how this is going to flow. So that's how we get there. So I like looking at the bigger picture as well as the here and now. Any questions at this point? Anything? Okay. All right. No. All right.
Question.
Yeah.
You mentioned measurable goals. Could
Yeah.
you give me an example of a measurable goal that one of the groups might have? For example, access to care or attracting practitioners?
Okay, sure. And that's one of the areas that I think we have some gaps, because I came in asking the same thing. You'll see some of the goals on here. Some of the goals is, it aligns with culture. Okay, so we want a better culture at the hospital. Culture of respect, professionalism, accountability, and how do you measure culture? And some of the initiatives was our departments getting along with each other. And when I saw that, I said, well, how do you measure that? I love data. I love data, and I'm very analytical. I can look at hospital finances, and figure things out pretty quickly. So I'm very data centric. So when I saw some of those things, I thought, well, how do you measure that? And as a nurse, you want to be able to measure your interventions, right? Did you bring the temperature down? Is the white count improving? This and that. So it is hard to measure some of these things. And we also have some gaps where we're not collecting the data. We're not collecting data. So I put a couple of things in place already about collecting data, at least through the emergency department. There's a spreadsheet that I put together about 15 years ago that measures, just your daily volume, your admissions, your transfers, your left without treatments, your left against medical advice, your left without being seen, door to doc, door to triage, who the physician was. So I've got this spreadsheet that tracks all of it, and I look at it every day. And I've been doing that one for 15 years. And that was very simple because I want to give feedback to the physicians saying, hey, your door to doc time is 45 minutes. And our expectation is less than 30. So we want to make sure we meet those expectations. So there are some areas that we're not collecting the data on, like access to care, okay? So when I got here in November, I think my first or second week, I asked for all of the transfers for the previous 6 months. I wanted to know all the transfers because what I had heard and seen is I looked at our census, I looked at our ER volume, and I figured it out pretty quick. I said, okay, something's going on here. So pulled the transfers out of the ED. I think we had like 250 transfers, 240, 250 something, and 221 came out of the emergency department. So I got a hold of, and I'm looking at it, and I got a hold of Dr. Roberts and Dr. Salazar. I said, hey guys, come and look at this with me. Come and look at this and see what you guys think. But what we had on there was presenting diagnosis or presenting complaint. And that's what the patient says when they walk into the door. Well, we can't go on that because oftentimes the discharge of final diagnosis is very different. So when I'm looking at the spreadsheet, it said we're flying out and transferring out someone who's not feeling well, cut finger. Like, why are we flying somebody out with a cut finger? Yeah, so I want to look at access to care. And so we looked at the ED transfers, and that's a work in progress. And now we did refine that to where I got the discharge diagnosis. And so we're digging into Dr. Salazar and Dr. Roberts. Dr. Salazar is looking more concurrent review. I don't want to do retrospective reviews for 6 months. I want to do concurrent reviews on these things so you can make some real-time adjustments and education with folks. So on access to care, I need to learn more about the clinic. Okay, I need to delve into the clinic. I'm talking to the providers, Dr. Lopez, a nurse practitioner, Brandy, nurse practitioner, Paul, and the staff up there. And I'm beginning to understand their scheduling process because what I hear is, anecdotally, I hear, they're not taking any more patients. And then I get the report on their productivity, and I say, okay, there's some gaps here. Why are they not, 100% productive? Why not that, what? Yes, ma'am.
Could you just take a 30-second break?
Sure. Is it because of my throat?
Yeah, you're driving your speech pathologist.
Right. Oh, that is great. Wait, Is that better? Sorry about that. Yeah, so I forgot where I was. I was talking about the clinic, getting the data in the clinic, and their appointments during the day. And I want to understand, okay, why is that? And I'm hearing that some of the providers double as hospitalists, so they carve out a couple of hours in the morning to be a hospitalist. But when you're a hospitalist with 4 patients, that doesn't take you that long. So I'm figuring, okay, so it's slowly, I'm peeling back the onion layer by layer and looking at this going, okay, because I don't want to go off half-cocked. I don't want to do that. I want to make sure I've got my ducks in a row and I understand the process fully. So I'm talking with Rhonda and Leanne about that in the clinic and the folks. So, all right, positive culture is a shared way of working and relating that supports staff well-being, teamwork, high quality, safe patient care. It shows up in everyday behaviors, decisions, and norms on the units and in leadership, not just in mission statements or slogans. And again, this is what I stress to the leadership team and the staff: patient-centered purpose, respectful civil interactions, and supportive, accountable leadership. And accountability starts at the top. We as leaders, and I stress this to the leadership team, we have to model and emulate what we expect of folks in the hospital. We have to model that behavior and hold ourselves accountable. So that's the culture I'm looking for. That supports well-being, staff well-being, teamwork, high quality, safe patient care. That's what I'm looking for. And if you do that, the money will come. if you do quality patient care first, and you work with each other, take care of the hospital, take care of each other, take care of the patient, take care of the community, and you do it in the right way, you shouldn't have to worry about finances. It'll take care of itself, most times. Business is patient care. So hospitals are a business, absolutely 100%. Healthcare, hospitals are a business. But the business of our business is patient care. We would not be here if it weren't for patients. We would just be brick and mortar without a purpose. All of us need to be good financial stewards so we can continue to serve our mission and purpose. So another thing that again, I'm very data minded, and I looked at this, another report in my first couple of weeks. I wanted to see the overtime. And so there are certain metrics in overtime, and I'm looking at it going, hey, where's all this overtime? And so I broke it down by department and had a chat with the senior leader. So we have cut our, I think our avoidable overtime by more than 50%. We've cut it in half. So we have to focus on the nickels and dimes and quarters, where the largest hospitals, they have to focus on the dollars. We focus on the change, right? And when you add these things up with the other, managing your expenses and growing the business and revenue cycle and all that, you can make a big financial impact just by having efficiencies, right? So use supplies and time wisely, judicious overtime. And if it's overtime that's related to patient care, something, hey, that's fine, just justify it. But I'm gonna ask you about it to make sure that as leaders, you own your business in your department. It's your business. So I just want to make sure it's going well, because we owe it to, number one, we're owned by the state of New Mexico. And why are we owned by the state of New Mexico? For the miners. So we owe it to our mission to be able to do this. Come on, guys, let's connect the dot back to our mission. Document completely and accurately, so coding and billing accurately reflect the intensity of services. Treat hospital money like your money. And patient satisfaction. Patients and families are our biggest influencers. How you make someone feel when they leave those doors or get discharged is is probably the biggest influence if they or their family or neighbor is going to come back. There's an old saying, they don't care how much you know till they know how much you care. And we've got to stress that.
Do they do patient surveys?
We do patient surveys, and I'm glad you brought that up. We do what's called Press Ganey, and Press Ganey is something nationwide, and they usually send a paper survey 2 or 3 months after a patient's been discharged. Usually the response rate, most hospitals, 13%, 15%, and of the responses, the majority are the ones who have a negative experience. And it's 3 or 4 months late. And it's very washed, meaning you don't get specific information, you get a score. Sometimes they write comments in, but it's very impersonal. You don't know what it is. You just get this generic score. And then Press Ganey ranks you among other hospitals. They put you in a percentile. So you're not necessarily comparing Raton to another small hospital. You might be comparing Raton to Phoenix or Albuquerque. And that's not a fair comparison either. But it's a patient perception of care. So I take the Press Ganey results with a grain of salt. Again, working with Press Ganey for 20 years, I understand, how they get their data and how they, assimilate their data and give it back to you. So I take it with a grain of salt. It's a good guide, but it's not very specific. So speaking of that, I've had, and we're developing, our first meeting is going to be February 12th, a Patient Family Advisory Council. This is where I want to get feedback similar to Press Ganey, but I want to get it firsthand, and I want to get it personal, and I want to get it closer to real time. So we're putting together a Patient Family Advisory Council, a PFAC, and the purpose is to listen, understand, and improve operations based on feedback from community members. First meeting is going to be February 12th. We'll meet every other month or so. 6 to 7 community members, they're going to meet every other month. Right, we're going to sit in there, and I mentioned this in the town hall, and Dr. Lopez is interested in being in there. I think Dr. Salazar said he's interested in being there, but I want the frontline managers in there. I can be in there, that's fine, or leadership can be in there, that's fine, but I really want the clinic manager, the ER manager, the med-surg manager, the lab manager, the radiology manager in there hearing it firsthand, the dietary folks, the EVS folks. I want them in there hearing it because they're the ones with the day-to-day impact on the feedback. And I want community feedback from the outside in. I want you to tell us what you want in healthcare as opposed to us telling you what healthcare is supposed to be, right? Does that make sense? I want you to tell us, you're the customer, you're the one getting care. And I want you to tell us what we're doing well and what we're not doing well. It's our house, we're in it every day. You know, that furniture in your house, it's just there. Then you bring someone over and say, oh, that table shouldn't go there. You know, put it over here. You know, you need to vacuum over here. That's what we're looking for. That's what I'm looking for. I'm looking for very constructive feedback and something that we can actually do. So we're going to start that in a couple of weeks. I'm real excited about it. Real excited. There's the Rural Health Transformation Program, the One Big Beautiful Bill, the OBBA. That's in the news a lot. And it's also related to the ACA subsidies that are being debated in Congress too. New Mexico was awarded $211 million for this year.
That's the whole state?
Yes, all the hospitals, $211 million this year. And it's broken down in 5 domains. And the New Mexico Healthcare Authority is designing and laying out that framework. So I got the email probably December 30th or January 1st or something from the Hospital Association, and I saw it on the news that New Mexico was awarded $211 million. So I immediately went to my desk, I started pulling out stuff. I said, okay, researching, here are the 5 domains, how are we gonna do this? And then I called Troy Clark, who's the CEO of the Hospital Association, and I said, hey, Troy, what's the next step? What do we do? And I think I had too much coffee that morning. And I go, hey, Troy, what do we do? He goes, Brian, he goes, we're waiting for the hospital or the healthcare authority to design it. They haven't even started this. I'm like, oh, okay. So we're waiting for the healthcare authority to design and figure out how this is going to work. Because this is brand new for every state. This is something, and the pace of government is going to be a little slow. And the healthcare authority is going to take a portion of that $211 million to set it up. And it's going to be distributed based on these 5 domains as you submit proposals. So if we get some money out of this, I'll be extremely happy, you know, if we get some money. But we're going to, again, plan, predict, prepare. When I saw this come out, I've already, you know, we jumped on it, and we're going to be ready to when they say, okay, go. I want to be ready for it. Yes, ma'am. Yes.
Okay, I have a question on that bill.
Diane, is it Diane?
It is.
I remember. I'm so glad to see you.
Oh, bless your heart.
That's what they tell me in Texas.
Yeah, so yeah, there's 50 billion, $1 billion over 5 years to each of the 50 states. New Mexico, 211, 484 million, but my concern here is who's going to monitor this? I always, when there's money coming into a state, in this case from the feds,
Yeah.
I always wonder, where is it coming into the state? Is it coming in at the governor's level or an agency level? And then my bottom line, I'm not from here, but we've been here for a while, is how do we track to make certain that that money gets down to the local?
I'm gonna send you to Santa Fe. That's how. You're 100%. It's 100% right. So how are you going to account and make sure that money goes to where its intended purpose,
Yep.
right? One of the things I like about Miners Colfax, and they told me this in the interview, that, hey, Brian, you got to understand we're owned by the state. I said, okay, so you have to understand there's bureaucracy. I said, hey, not a problem. I understand bureaucracies. I've worked for corporations. I said, what I like about that you're owned by the state is that there's transparency and accountability. You have a legislature who's looking at these monies. You're not a private corporation. I've worked for private owners and private equity before. I don't want to do that. I had some very bad experiences in the last couple of years with people that should not be in this business, and I don't trust them. So you're dead on about how are we going to account for this money and make sure it goes to the right program. The Healthcare Authority, which is the regulatory body for the state of New Mexico, in California they call it CDPH, California Department of Public Health. In New Mexico, it's the Healthcare Authority. They're the regulatory body that's going to be setting up these 5 domains and awarding the money through the proposal process. So they're going to do it, and they're, again, the regulatory body that reports to, I think they report to the either the legislature or the governor directly that has that oversight. So they're the oversight body to do these things.
But locally, I'm wondering if maybe we should be thinking about establishing, creating a group or an oversight committee or something that interfaces with the legislature, that we have direct daily contact to monitor this stuff. The money seems to come into the state, and this is in education as well, but the teachers, by the time the money or the grants or whatever get down to the community, suddenly there's no money for the, express purpose. So we know how this works. We've seen it goes through agency and sub-agency, everybody takes a piece. It's an administrative cost. By the time it gets down to the user, it's diluted. So it just seems like it would be prudent to begin thinking about putting together an oversight group at the local level and having them.
So we have a board of trustees. We have a board of trustees that are appointed by the governor and Dr. Cotter. So we have a board of trustees. And again, I mentioned I'm very overly transparent with folks. And when it comes to money, I'm going to be completely transparent. And I want to know where the money's going to, because I'm a state employee and we owe it to the taxpayers and again, the miners and the people of the community. If we're going to get public money, and think about it, most dollars that we get in healthcare is public money. It comes through Medicare. The majority of their money comes in, and even if it comes through a private commercial company, it still originates in the Medicare in what people pay into it. So you're absolutely right. We need some oversight and accountability, and I think one of the local bodies that to do that process is our governing board. We have financial reports every month to the governing board. And if the board, wants to get more granular and detailed into this, I would welcome that if they want to do that. So yeah, we do have a board, and they're appointed by the governor, and I want us to be in. I think the board members can attest the last couple of board meetings that I want a lot of financial transparency. I want more financial transparency. Okay. Yeah, that's one of my big things, because again, I've had experiences where I worked for some folks that should not be in this business. They should be printing license plates. Yeah. So that's that. 5 domains, healthcare authority, a black lung program. We executed a couple of new contracts with Canyonlands and NowCap agreements to expand our reach. And I want to work with Dr. Sood Moore to get another radiologist that is certified as what they call a B reader. And these are radiologists that are certified to read black lung and give a black lung diagnosis. And we're going to explore, and this relates to the OBBA, explore remote patient monitoring and direct-to-business services with mining companies directly. Remote patient monitoring is when you can you have a wearable device that will track your heart rate or your blood pressure or something remotely. So if you're working in the middle of New Mexico, Nevada, Arizona in a mine, and you're a part of the Black Lung Program, we can monitor your vital signs or different statistics on a real-time basis, as opposed to every month or every couple of months. And there's ways to get paid for that too. So there are billing codes to get paid for that. And that's important. No money, no mission. Rural Health Transformation Program. So these are the 5 domains. It's a lot of stuff up there. So expanding access to care in rural communities. Rooted in New Mexico, building tomorrow's rural healthcare workforce. So employment, sustainability. Rural Health Innovation Fund. Enabling community design, community-led change. Bridge to Resilience. Rural Health Sustainability and Innovation Center. Technical assistance, a lot of financial stability tools to rural hospitals and clinics so they can remain open and right-size their services. Rural health data hubs. So there's a lot of access in here, there's financial things in here, and there's a lot of IT components built into these 5 domains, but a lot of it is around the expanding access. Let me ask you guys, what are some of the services that we're lacking at the hospital? What are some services that we may not have here that anybody in the community might need. Mammograms. Okay. Yep.
Vision care?
What's that?
There's not an eye doctor in town anymore?
Yeah. Okay. Yeah. Like an ophthalmologist.
Yeah.
Okay. Yep. Yeah. I think we used to have that.
Yeah, he left like 2 years ago or something.
Yeah. Yep. And mammograms. I think the truck comes once a month. Oh, that was the MRI that comes once a month, I think.
Yeah, they had to fly me to Amarillo last month because they wanted an MRI right then.
Right.
So yeah.
Yeah, we need better access for MRIs, mammograms, women's health, and I'm going to talk about women's health just for a minute. What about behavioral health? Do you think behavioral health is an issue? Substance abuse, is that an issue here in town? Is that something? Is that
Mental health.
Yeah, all mental health. Whether it's maybe family stress, financial stress, or you get into some of the more diagnosed conditions. Yeah, every community has it. And somebody told me once, well, Brian, if we have that, we're going to have a lot of behavioral health, mental health, crazy people walking the streets. I said, you already do. Wouldn't you rather have them on medications and treatment? They're already there. So.
Brian.
Yes, ma'am.
There is a substance facility opening up in February. They're renting a place above Solano's. So there is a new facility opening up for substance.
Oh, good.
Yeah. So
Good. Because the ER is always the catch-all for everything, right? ER is the catch-all for everything. And when I was an ER nurse, we used to joke, hey, if I wanted to be a psych nurse, I would have been a psych nurse. If I wanted to be a pediatric nurse, I would have been a pediatric nurse. Because that, in the ER, you get all kinds of stuff. You either get babies that are coming in, really sick at 2 a.m, or you get some crazy person. I was like, oh, I signed up for trauma. I signed up for this, neuro and strokes, but you get everything. So we want to help the ED and make sure people, and the ED is not a primary care focus for these folks. You come in, the ER is a totally different focus. It's treat them and street them. We want to have, like you said, these outpatient services that can more definitively treat and care for people with these types of disorders and things. Yes, sir.
Right now, Brian, especially during this cold inclement weather, we don't even have a warming station.
Yep.
In Raton, let alone an emergency shelter. And I imagine what you end up seeing are people who are suffering from frostbite or hypothermia, things like that. If we could do something ahead of that, then arriving in the emergency room, that would be a needed service.
Yep. And I'm really looking forward to working with Cynthia on this and the city. And again, in my mind, the hospital is part of the fabric of the city, like law enforcement, fire, EMS, and healthcare services. We've got to be hand in hand with the city. And that's one of the reasons I went to the city commission meeting and we talked that night and, getting to know some folks in the city. And we've got to be a part of that. So when it comes to basic human needs, we have an obligation, we do have a seat at that table. We've got to do that. And I've worked in, some really cold places, some really hot places, and we've had heating and cooling centers. In Phoenix, you have to have cooling centers, and here you have to have heating centers. And Barstow, you got to have everything. When I was in Barstow, California for a while. So, folks will come to the ER, and they'll get discharged at 2 a.m, and they'll camp out in the lobby, till 10 o'clock. Because it's, and how can we, I'm not going to put them out when it's 10 degrees outside. How can you do that to someone? When I was working in the ER, I was the same way. I said, I'm not going to kick this person out. No, that goes against what we do, what our mission is. So those are the 5 programs, the OBBA, the $211 million. Strategic Framework, SLT, we're interviewing telemedicine platforms. Projected, I want to get this up and going by spring of 2026, so March, April timeframe. We've got to go through vendors, we may have to go through an RFP process, go through contracting, and that takes a while. We need to be able to do that. Clinic rollout is going to be first. Do you have in mind any clinical services that we can do via telehealth? What about urology?
2 hours away.
2 hours away, so maybe a teleurologist that can come in, maybe a telepulmonologist and get some devices where we can do that.
Gastroenterology.
GI, okay, yeah. So these are, yes ma'am.
This really goes to your previous question about services overall, but it would be so important to have a NICU facility here.
Yes, we do have a, Dr. Salah, is he more, he's more than a pediatrician, right? Is he a
Dr. Salah is a pediatrician.
Sala, a pediatrician. He's not a he's not a neonate.
No, he's not a neonate home.
I always pronounce it wrong. Is it Sala?
Sala, S-A-L-I-H.
Sala, not Salah. Sala. Okay. Sala. Okay. All right. Yeah. For NICU, and that is going to be. And that's sort of on here. So clinic rollout, improve access to our communities, different specialties. So some of the provider recruitment, and I put this down in bold under continue to solidify the OB program. Yeah, that is continue to solidify the OB program. Up north in Trinidad, they don't deliver babies. Down south in Las Vegas, they don't deliver babies. So who is taking care of moms and babies? We are. We have to. There is no way that there's just no way we can that program is going to go down. There's no way. A lot of hospitals, the OB program loses a ton of money. When I was in Barstow, I think we were losing $1.5 to $2 million a month because due to OB, because of the staffing, lack of deliveries, all the liability and all that. But we kept it open because where are you going to deliver babies? They're going to come in the ER. They're not going to get prenatal care. And the infant mortality is gonna rise. And if you break down infant mortality between Caucasian, Hispanic, and African American, there's such a disparity. We have to have infant mortality. Then you start looking at low infant birth weight rates, and that is a problem, especially in rural communities. Where are you going to go to have healthy babies? Right. So again, these are things that are bedrock, not gonna change. 100% not gonna change. So we did secure Dr. Gurley and Dina Lewis, who's a nurse practitioner for outpatient cardiology. Dr. Gurley's group, I think they all mostly retired last year. And so we had to get an independent contract with him. So he's actually an employee of the hospital now, part-time employee. And Dina is a 1099 employee with the hospital. So we had to secure them before the end of the year, which we did. We kind of pulled a rabbit out of a hat with that one. Is I wanted to make sure we had continuity for outpatient cardiology. Dr. Gonzalez is a new emergency department physician that started last week. Dr. Ryan Murphy is an endoscopic surgeon, so he does colonoscopies. So anybody in here needs a colonoscopy, please go see Dr. Murphy, Ryan Murphy. Okay. Then we have Dr. Ira Murphy, no relation. She is an OB physician that started with us, I think, in September, October. Her first week here, and I hope this continues to happen, her first week here, we had a record amount of deliveries. I think we had 7 deliveries her first week, and then we had a clinic full of patients. So I'm thinking, oh, great, you bring the rain. This is great, we need you here. And she and Dr. Roberts alternate every 2 weeks. So one covers the first half of the month, the other one covers the second half of the month. So theoretically, we should have an OB doctor here, all month. She's really good. I think she's worked in Arkansas before that. Dr. Ian Wright is a general surgeon, and he is waiting for his licensure for New Mexico to be finalized. We anticipate him in the next 3 to 4 weeks, sometime in September. He's a general surgeon, very energetic. I've had a couple of conversations with him, and he's really anxious to come here. If you think I talk a lot, he talks a lot too. But he's real excited, so I love that about him. So we've got some good new physicians in here. We had a new hospital start the other day. Dr. Stanislaus, Amos Stanislaus, I met him today. Very kind, very, very good person. So he's going to be doing our temporary, he's what's called a locum, so he's a temporary doctor. He's going to be handling the inpatient admissions as a hospitalist for us right now. So he started this week, so we have continuity in that. And we need more surgeons. We need some more OB, and we need some more support, bench strength in our outpatient clinics, especially in OB. So we've got a couple of folks in OB, family practice / OB docs. There's Dr. There's Morgan Shire, and I'm blanking on her name now, from La Junta. Swanson, Amanda Swanson. Yeah, thank you. So we're looking to, Morgan Shire is already on staff, but we want to get her more into the clinic, get her more, again, where are these women going? If they're not coming to Raton, we need to build this, get it from Trinidad, get it from Las Vegas, get it from these outer areas to support this program. We've got a beautiful labor and delivery department down there. I mean, it's absolutely amazing. Great staff. The nurses that I've met down there are just the deeply caring folks, and they love, and this is OB throughout the industry. You get an OB nurse, and you know they're an OB nurse. They are so passionate about what they do, and they will do everything in their power for the mother and the baby, and I love that about them. And Shelby Wold is our nurse manager down there. She's doing a great job. And Dr. Roberts, I think they've got a great program. We need to get the word out and welcome people more for women's health. And that goes along with mammograms. And that's a whole, service line of women's health. And mother baby is just, is a part of it. We need to support that. Because who in our households makes the healthcare decisions? Mom. Who takes care of the kids? Mom. Yeah, 100%. And so, if we take care of the moms, right? What's the old saying? If mama's happy, everybody's happy. Yeah, and if mama's not, we're not. So we got to take care of that. Intermediate care at the DOU. So the ICU was closed a couple of years ago. And again, part of our mission is to expand care. If you're not expanding care, you're falling behind in this business because everything's constantly changing. People don't want to, the commercial payers, Medicare, they don't want to pay you as much anymore. They're always looking for ways to not to pay you. So if you're not expanding and growing, you're falling behind. So when the ICU closed, and we have transfers. So again, working with the medical staff, looking at the appropriate transfers, having a dedicated hospitalist in the hospital, not locums, because locums you pay a ton of money to, and they're not invested in the community. You want a hospitalist that is invested in the hospital and the community. If we can convert these transfers appropriately, we can grow our census and get our nurses to expand their capabilities. Our wonderful speech therapists and our lab and X-ray. So right, yeah, we need you. So if we can open up not an ICU, but more of an advanced med surg or direct observation unit or some sort of intermediate care, I think we need to do that this year. My goal is to get that done before the end of the year. So, and again, that's going to take working with the medical staff, looking at the transfers, having more services available to us. And I think having some of these surgeons come on and having that medical backup and support. Because just because you're a hospitalist, it doesn't mean you can handle everything. We've got to have that consultant support as well. So we need to build that medical staff infrastructure. But I would love to see opening up that unit once again. I think there are 4 beds in there. We've got the talent in-house. We've got the talent. We can do it. We just need the process and execution on it. So, and again, it would be great for Raton because we don't want to fly you out. We don't want to add another $10,000, $15,000 bill to you for an air-vac, right? We don't need to do that. It sends the wrong message. Clinical and ancillary operations. This is more there's just some updates. And I'm sorry, I'm going to speed it up. Are you guys getting tired of listening to me? I've seen some people wander out, so I'm getting the hint. All right, sorry. But I get real passionate about this stuff. So radiology, we have a Fuji project that is just about finished. In the last 2 years, I think we spent close to $1 million on upgrading our digital radiology. And what does that mean? How does that convert? What does that mean for the public? Digital radiology in this new state-of-the-art stuff with Fuji means we can give you better image qualities, and the physicians will have a higher clarity and be able to interpret those x-rays with more accuracy and more timeliness. So you're going to get better care faster. And you're not going to have to say, oh, you tell the x-ray tech, hey, you need to go back and redo these films because you didn't get the angle just right. These are going to give you much clearer, it's like a Polaroid versus a digital camera. We got a digital camera versus the old Polaroid for the physicians to be able to treat and care for you quickly and better. So, and that was about $1 million. But that, it's not real sexy stuff, right? It's not a big sign up front, but these are the things that happen behind the scenes. We have a lab consultant that came in. We had some issues with the lab, doing a great job. So the lab is actually doing very well. And pharmacy, Ray Luna is our director of pharmacy. We had some upgrades that are already completed in our sterile compounding room it says nearing completion, but they're done. And they've already worked on the hazardous drug program to ensure all staff are trained. So there's a lot of work happening day to day in there to ensure the continuity of safe patient care. This is kind of hard to read, but these are what's called interoperability functional measures. and we scored really well. We've got some top scores in here. Electronic prescribing, 99%. Drug monitoring programs, 83%. Provide patients electronic access to the health information, 94%. So we're constantly, and these are constant measures that we have to do, constant measures. And we do have issues. We're not perfect. We are not perfect, and we recognize that. So as things happen day to day, it gives us an opportunity to uncover that area to improve in areas that we may not have seen. And we've had some issues in medical records, and we have been had the opportunity to improve our customer service in medical records. I'll just leave it at that. Quality, this is Ray Hager. Some of her areas of responsibility, audits, regulatory reporting, process improvement, data analysis, infection prevention, monitor, investigation, reporting, employee health, regulatory compliance, quality assurance and performance improvement, that's QAPI, Press-Ganey, patient satisfaction, action queue, event reportings, culture, professionalism. We did a culture survey last year, and it gave us some eye-opening results that we need to work on. Community hospital trends, ICRA, OSHA regulations, immunization, flu vaccine programs, fit testing, employee safety. So Ray Hager is on our leadership team, and she has a lot of things that she does on a day-to-day basis, not only to protect the patients, but to protect the staff. So she's very responsible for this, and she's excellent at what she does. Some of the latest wins, we had a 35% participation in our staff culture survey. We adopted a covenant of respect and professionalism among our management staff, and we had just culture training. Again, when I came on, when I filtered this down from senior leadership to the managers to the staff, is professionalism, respect, and we are adults, and we will take care of each other that way. No hospital-acquired infections. In 2025, this is something that very few hospitals can say. So this is a very measurable performance measure in hospital-acquired infections. You go into a hospital, if you're not sick, we're going to make you sick. And the longer you stay in a hospital, you will get sick. And that is a true story. You're going to get Klebsiella, you're going to get a catheter-associated UTI, you're going to get some sort of bloodstream infection, from a central line, and you're going to get something. We'll find a way. We will find a way. Employee health, very successful flu vaccine program, over 96% of our staff, and we had no needle sticks in 2025. That's another huge win. That's a safety measure. We don't want to have that. So again, when it comes down to practice and all this, and Ray Hager is leading a lot of this in quality, so I really appreciate the work that she does. So there are some really good things happening there, and again, we have things that we need to work on as well. One of the other areas in infection prevention that often gets overlooked is EVS and housekeeping. You walk into that hospital, and I look at it, and I think, the building's only 2 or 3 years old. No, it's not. I'm not sure how old the building is, maybe 15 years old, 14, 15 years old. And it is aging very well. The floors are spotless. We walked through this with Juanita and Sabrina, our EVS managers, last week, and we were in a quality meeting, and they were talking about the black light surveys that they do, the hand washing monitoring that they do. I mean, they really look and track in EVS and housekeeping the control and the not spreading of germs, especially in these winter months when everyone's close together. So our EVS and housekeeping is one of the leaders in these results in infection control. We can't do it without them. Then also our maintenance guys. If you keep that hospital in working condition with the HVAC systems, the electrical, all of that, and especially the HVAC systems, you can't have an OR without an HVAC system. You can't have a hospital. So, I try to thank them. You got Paul in there, you got Jason in there, you got Anthony in there. These guys or Josh, you got Josh in there, you got a lot of folks in there that do a lot of work behind the scenes to keep that place looking nice. And its sustainability. Again, it looks like a brand new building, but it's 15 years old. So there's a lot of folks in there keeping the place moving. and that contribute to these results that you wouldn't normally think of. You normally think of doctors and nurses. Well, what about housekeeping? What about maintenance? They're the ones that are actually doing the hard work. We report it, that's all. And I don't want to take the credit because the credit needs to go to them. Respiratory, Stephen Deaton is our respiratory manager. He's doing great. We partnered with Medco to secure a consistent supply of oxygen tanks to streamline discharges. So if if you need an oxygen tank at discharge, say you come into the respiratory thing and you need to be on oxygen, we secured it to where you're going to leave with an oxygen tank. We're not going to say, okay, well, you got to drive to Amarillo, you got to drive to Colorado Springs to go get your oxygen tank. No, we're going to give it to you there. So they worked really hard to have that continuity that you walk away with or wheel away or whatever with an oxygen tank. We work at the Black Lung Clinic and Cardiology Clinic. Care management, utilization review. Again, that's another area that is misunderstood by a lot of folks, but it's critical to our needs, and that is Crystal Armstrong. She's our senior leader in case management and utilization review. She's the one that coordinates with the physicians, the medical staff, and their charting to ensure insurance authorizations and a continued stay and ensure that there's still medical necessity for people being in the hospital. So Crystal's got a very, very important job in there. And she works closely with medical staff and with the business office, myself, and Lonnie as the CFO. So financial health, here are some revenues. The blue line on the left is the first 6 months of 2026. The orange line in the middle is the full year of 25, and the green line is the full year of 24. Net patient revenue, we're about tracking as previous years. Total revenues, because that's net patient revenue over there. Then we have a lot of other revenue funds through the state of New Mexico. And rural hospitals tend to have to be subsidized to a certain degree by programs, just because you don't have the volume, you don't have the payer mix to support all the requirements of an acute care hospital. So you have all the requirements, but you just don't have all the patients that come in. So we are subsidized quite a bit, and our total revenues in fiscal year 25 was a great month. You see that orange bar is pretty high up there. We're not going to get close to that because some of the land grant money is tracking to be about $5 million short of that this year. The land grant money is not going to match. In 2025, it was $14 million, and the first half of this year, we've had 5.3. So, just double that, you got 10.6. That's less than the 14 from the previous year. So what that tells me is that we've got to do better operationally. How do we do better operationally? Well, we get, communicate, culture, and all that stuff, but we've got to get more patients. How do we do that? Well, sit and talk to you and get more services. So it all fits together, right? All fits together. That's what I love about this. Here's our expenses, kind of the same thing as our revenue. We're tracking a little bit more than we did last year. We got to pinch our pennies. We've got to live out of our pantry and not go to the grocery store every day. That's another thing. Hey, live out of your pantry. Why go into the grocery store when you got food in the fridge? You got to save a little money. So we got to try to save a little money and watch our budgets. Capital outlay. So this year, 26, we had $871,000 for capital outlay. $91,000 for computers. So in our budget crunches, we spent almost $100,000 on computers. Those are the things you take for granted. We spent $100,000 on a boiler replacement. Nobody ever thinks of a boiler. These things are expensive, and if maintenance doesn't take care of them with the chemicals and the different things, they're gonna blow up on you, and you're gonna have to replace it and spend another $100,000 the next year. So these things usually have a lifespan about 10 to 15 years. So these are all the things in the back area. You spent almost $1 million on things that people don't see every day. Gas dryers, we got to spend $52,000 on gas dryers. So imagine going to Lowe's or Home Depot and getting a sticker shock for a dryer. It's something that we take for granted, right? But these things cost real money. Where does that real money come from? Providing excellent care. Again, I'm trying to connect mission back to purpose and giving people real life examples. I say this to the folks in there. If you want no IV pumps, hey, how are we going to get the money for new IV pumps? Got to take care of patients. Take care of your patient. Make their experience happy so they write something nice to us and tell their friends. Not that hard. Long-term care. Up on the hill, 1905. 7 years before New Mexico became a state, opened in 1906. A lot of the folks were born in that hospital. There you go. There you go. Moved to the new old hospital in the 1970s, and we have some history on it and one of our shared drives at the hospital, computers. Long-term care, licensed for 37 residents. Main objective is first to the miners with a room and board at no cost to them for working in the mines. And again, as I'm learning the history and talking to some of these folks, it's an honor and a privilege to be able to do this for them. Because look at their sacrifice in their lives for not only their families, but for the state. Second objective is to provide living quarters to the minor spouse, however they pay privately through an insurance program or Medicaid. They do accept community individuals, but only if there are no minors or spouses that are ready to admit. So the long-term care center up there, and Stephen Kelly is the administrator of the long-term care center. He is doing an amazing job. He's a great leader. He's got a great team up there. And keep doing what you're doing up there, Steve. And if there's anything I can help support you, I don't want to get in your way. If it's not broke, I'm not going to try to fix it. So he's doing great. We have a fitness center in long-term care that's open to employees and to first responders, law enforcement, and other emergency response personnel. And we're looking to do some community yoga and Zumba classes coming up too. And it's open 24/7 via badge access. So this is open to all of our employees. I frequent it. I go there and work out, hopefully at least once or twice a week if I'm not swimming. And question time. So sorry I went a little long. Sometimes, there's too much information sometimes. But if you want to know, again, I believe in being transparent. And, because I got to face you in the street and the coffee shops too. Yeah. I'll sleep tonight.
In the past, we've been overly dependent on traveling nurses.
Yep.
What can we do to reduce that ratio and get more local?
So Paul, right? So Paul was asking about travel nurses. 100% we have too many travel nurses, and when you have travel nurses, your quality goes down. It just does, because they're not invested in the community. They're not your neighbors. So in non-state owned hospitals, there's more flexibility for pay and to the rate of pay for folks. You can adjust that as long as you can commit to a return on investment. As a state-owned facility, and this is one of the challenges that I'm learning about, we have state pay bands that people are in those pay bands, and the travel nurses and COVID really. I was in California. We were paying travel nurses $250 to $300 an hour, and that's not sustainable. We can't afford that. So that has come back to reality a little bit in the last couple of years, but they still get paid a lot. And it's part of the One Big Beautiful Bill Act. Part of that Rural Health Transformation Fund is to work on employment, long-term employment. So there is money out there. We have to design a creative way to work with the Legislative Finance Committee and I don't know how successful we can be in this, because we have those pay bands that are set by the state, because we're not a private hospital. That's going to be a challenge. But here's what we can control. So some of these things are out of our control. But then I ask, okay, what can we control? We can control how we treat people. And so if you can get people there because of the culture and say, hey, I want to work at that hospital because they're doing good things. They support me in my education. They treat me fairly as an employee. They encourage my development. If we can do those things better than the hospital down the street, then we have a leg up. In our town hall last week, there was a nurse at long-term care. She's an LPN at long-term care. She came up afterwards to me and she said, Brian, I want to go from a traveler to an employee of the hospital. I'm from Florida and I want to move here because I love the long-term care so much. And so again, what Stephen Kelly is doing up there with the culture that he's created, he's flipping somebody from a traveler to a full-time staff up here, our own. If we can replicate that and keep doing that. So again, we can't necessarily control the pay, because that's what people want. Hey, you pay me, and nurses are fickle. We are fickle. If you pay me $5 more an hour, hey, I'm gonna work at the hospital down the street. And if that hospital comes back and pay me another dollar, I'll switch back. That's what nurses do. They do. In other folks. So we can't control that, but we can control how we treat people. in the culture in the hospital. So that's one of the things on the strategic plan is the culture for this year, to retain, because we don't want that turnover ratio. We don't want that turnover percent. We got to keep the turnover down. We want this to be a place where people want to work. And we're also getting involved in the New Mexico Rural Health Network, the hospitals in New Mexico, the rural hospitals, and we're also actively involved in the New Mexico Hospital Association on different committees. Ray Luna is the committee chairman for our pharmacy committee throughout the state. So we're getting the MCMC name out there throughout the other rural hospitals. So trying to let people know. But no, that's a problem we're going to be struggling with for a while, travel nurses.
I was talking to my brother, he's a retired coal miner, and he said at one time, I don't know if it's still in existence, but there was some kind of program to help pay for nurses, you know, with probably the thing that they would come, you know, and work so many years or whatever. But I don't know.
I don't know if it's in existence with the state. We were having
I think it was through the Miners Trust.
Oh, through the Miners Trust. Oh, I don't know. I don't. Says.
I don't recall that in my opinion.
Okay. I can check with Barb. Barb would know. But again, back to that Rural Health Transformation Fund, if we put something together, hopefully we can get some money, you know, a portion of money to that would be designated for that purpose, you know, to your point, Diane, to be designated for that purpose, we're accountable for it. So, yeah, because we need a sustained workforce. We need a sustained workforce. And, you know, so I got my blood drawn. I had to get some blood work done a couple of weeks ago. And I went into the lab, and there were two young, I'll call them young ladies. I don't want to call them girls. But, and so they were drawing my blood. And I said, oh, well, you know, what college do you guys go to? Are you in college? Are you going through phlebotomy school? And they go, no, we're in high school. Wait, whoa, hold on a second here. You're in high school and you're putting a needle in my arm? What the heck? You know, and so they were fantastic. They were great. So getting into the high schools and giving them opportunities and letting them know, hey, you can work in the lab, you can be a phlebotomist, you can be a respiratory therapist, you can be a nurse, you can be a doctor, you can work in x-ray. And so that's part of the workforce development. So I was really happy. And I think we took a picture and put it on Facebook. A couple of young people were drawing my blood. It was kind of fun. They did a great job. I'm like, okay, great. So one did it. And I said, well, do you want to try two on the other arm? And so the other girl did it too. And we took a photo of. I don't mind, you know, hey, it's what we do, right? So it was a lot of fun.
Brian?
Yes, ma'am.
An issue, a real issue here is transportation, lack of transportation, medical transportation. And we would need to have a longer conversation about this, but the Raton is 6 miles south of the Colorado border. When you travel to Trinidad, see MedRide and several other companies up and down I-25. They won't come south. It's a state line, you know, that's
they don't cross the state.
A barrier. So how to address it, I spoke with the Southern Colorado Council of Governments, and they were not interested, and tried to contact MedRide and got no response, but it's an issue that really needs to be addressed and resolved, and it might, maybe we need the city council, the county commissioner, our state legislators, representatives, maybe connect with folks in Colorado to see how we can get that medical transportation, which is so close, come down here and serve Colfax County. That's a big ask.
It is. It almost sounds like an entrepreneurial business opportunity.
Brian, I've got some information about that.
You do? Okay. All right, Neil. Have you share? So I've met with Chief Burke too on a couple other transportations. But Neil, sir, Mr. Mayor.
North Central Economic Development District and the aging part of it, non-metro area, youth on aging, what I was director of for the last 4 years, has a volunteer driver program. and it is for non-medical emergencies. They'll take seniors, right now it's just 4 seniors, 2 doctor's appointments out of town, at no cost to the senior. The volunteer drivers are reimbursed for their mileage using their own vehicles, and they get a per diem for lunch if they're going to be gone, 4 or 5 hours. The thing is, though, you need the volunteer drivers. But it so happens to be that tomorrow, the director of that program is going to be at the Raton Senior Center. So if anyone is interested in being a volunteer or hearing about how transportation can happen, it's going to happen at 11 o'clock tomorrow at the Raton Senior Center. So it's a pretty good program. We've had very good success in Taos County and over in, which we're well over in the Clovis area. I think that's Roosevelt County. But very good success in Taos County. And what it does, it also helps that senior that's getting that service, gives them time to have a social relationship with that driver. And that's what a lot of seniors need. A lot of our seniors sit at home. They don't have any interaction with anybody. Sometimes a caregiver comes in and they have them for an hour or 2. But these drivers are starting to build these relationships. So now, not only are they taking them to doctor's appointments, they're taking them to the local trips as well, to the grocery store, pick up prescriptions and things like that. But that is going to happen tomorrow at 11 o'clock at the Raton Senior Center. Anybody interested, please come on down.
Quick question. Can we travel across the state?
We've got permission to travel across the state. I'll have to check again with Aaron tomorrow, but yes, they can. On the
Appointments like in Pueblo or Trinidad or someplace like that?
Because in Clovis, they have taken them to Lubbock. So I'm pretty sure we can still do that, Dick.
I have 3
town as
people
well?
who,
Pardon?
they can transport in town as well, because a lot of times seniors need
Right.
access to their
Yes.
doctor's appointments
They,
here.
it was basically set up at the beginning for non-emergency medical appointments. But then it, like I said, it's transformed and transitioned now into it's like a senior Uber, except it doesn't cost you anything.
We'd be happy to publicize that in the Ratonian and help recruit.
Okay. She's gonna bring flyers and that tomorrow. She was supposed to email some to Billy, but I haven't heard it on the radio, so we'll get with her tomorrow.
Brian, can I ask one question? So I experienced a situation with my father in the emergency room in November where he had to be taken to Color Springs at UC Health. So I asked, okay, when will the ambulance come? Well, they don't have ambulance during that time. And this was probably from about, he was there from 8 till 6 in the morning, and this was in middle morning, midnight or 1 or so. So come 6 o'clock, it's time for him to transport, but there's no ambulance to take him, so they have to fly him out, even though it's not a flight for life. So the guys came from Oklahoma to the airport here, and then they had a car here. An ambulance actually picked my dad up with them, took him back to the airport, and they flew to Colorado Springs.
Yep.
I was told I couldn't fly with them. When the guys got there, they said I could fly with them. I mean, there needs to be a little bit better situation because we have to pay for that flight.
Yeah.
When there was no ambulance, I couldn't take him because he needed to be hooked up. And then I was told I couldn't fly with him, but then they said I could. So, it's just the situation that could have been better for us.
Brian,
yeah.
I'm still going to advocate for professionals. Like you mentioned, it could be an opportunity, business opportunity, right? Did I get it?
I just see a gap and I think, well,
Because
probably money out there somewhere.
he's talking about local. She's really getting to the point of the difficulty of this. Our people are being flown, and my husband's been, driven by Raton Fire Department to Pueblo and to Albuquerque and flown to Amarillo for a hip fracture. And it just doesn't make sense on any level, and it's incredibly expensive. And, there will be promises made and, but the reality is different on the ground. So That's another time for another conversation, but I'm just saying that it is a major issue for lack of.
That was one of the things that I expressed to Dr. Salazar and the hospice about, let's keep Raton in Raton what we can keep. We can't add $10,000-$15,000 to someone's bill that's outside of the hospital. I mean, then we're going to get to a point where someone's going to pay an extra $20 in gas just to bypass the hospital. If you're going to go there anyway, if you're going to send me out, I might as well just drive there myself and save myself $15,000. I mean, that's what I would do.
I asked, they said no.
What's your opinion to be hooked up?
but I did have a conversation, and this is similar to other rural hospitals that I've worked with, the local fire chiefs and the local ambulance company, and this is a common thing. And I had a conversation with Chief Burke last week and with Dusty about transportation. So it is a concern. Dr. Cotter?
We're just going to point out that, medical transport is not under the umbrella of hospital, it's under the umbrella of city services, Raton Fire and EMS.
Yes.
And since I've been here, we don't have any paramedics. We have 1 or 2 intermediates and the rest are basics. So they can't, depending on the acuity of the patient's care, will depend on what if Raton EMS can staff transport or not.
Yeah, and this dovetails in why Cynthia and I get along so well, and we talk a lot, because we've got 2 separate entities. You've got a hospital that is owned by the state, then you've got a city municipality, that has their issues, and the fire department reports to the city municipality. So you've got 2 separate organizations with their structures, and this is that interdependence that we have to work on. And when I mentioned the hospital is part of the fabric of the community, this is where Cynthia and I are going to work together to improve and raise that tide so all the ships can raise. And this is one of the ships that we need to raise is the transportation, not only for acute emergencies like this, but also for behavioral health. There's a state program that came out that's not working well for us, and I gave that feedback. to the state last week. They were in my office, and I told them, I said, hey, this isn't working out for us. You need to relook at this. So we are advocating for all of this. No, honest to God, and we are doing this. So yeah, but Cynthia and I and we're going to be working real closely on these issues, and that's why we had a really good meeting yesterday with our senior leadership team with Cynthia, and so we're going to be working close together. Yep, is what we do.
How many of you really appreciate the breadth and depth of coverage of that talk and the transparency? So what we will do is identify the kinds of healthcare enterprises we need to bring here, including healthcare transportation, and go after them actively. Thank you so much for coming tonight, and we'll look forward to the next meeting with all of you.